It is 2 in the morning. You are awake again. You shuffle to the bathroom, come back, settle under the covers, and lie there for 20 minutes waiting for sleep to return. At 4, the same thing. And before the alarm goes off at 7, one more time. You are tired. You have been tired for months. And somewhere along the way, you accepted this as just what your body does now. Just what getting older looks like. Most people never question it beyond a certain point. They drink less after 6 in the evening. They avoid coffee after noon. They try to time everything just right so that maybe they can get through the night. And sometimes it helps a little, and often it does not help at all. Because the fluid restriction and the timing adjustments, while reasonable as starting points, are managing a symptom without touching the cause. Waking once during the night to urinate is within the range of normal for an adult over 60. The bladder capacity decreases with age. The kidneys excrete more fluid in the overnight hours than they once did. A single nighttime trip, particularly in someone who drinks adequate fluids through the day, is not a clinical concern in isolation. But waking 2, 3, or more times every night is a different matter. At that frequency, the disruption to sleep architecture becomes clinically significant. Deep sleep is repeatedly interrupted. The restorative processes that depend on uninterrupted sleep, immune function, memory consolidation, hormonal regulation, tissue repair, are cut short night after night. The fatigue accumulates into a chronic deficit that affects cognition, mood, cardiovascular health, and metabolic regulation in ways that extend far beyond feeling tired in the morning. And in many cases, the frequency of that waking is not being driven by how much you drank before bed. It is being driven by something happening inside the body that is worth understanding, and in many cases, worth addressing specifically. Before anything else, what I share in this video is educational information only. It is not medical advice. If you are experiencing frequent nighttime urination, particularly if it is new, worsening, or accompanied by other symptoms, please speak with your healthcare provider. What I want to give you today is the understanding to walk into that conversation with specific, informed questions rather than a vague complaint about being up in the night. I am Dr. Andrew Carter, 15 years working exclusively with adults over 60, and the reason this topic matters to me is that nocturia is one of the most consistently undertreated symptoms I encounter in this age group. People accept it. They adapt around it. They do not bring it up because they assume it is expected. And in doing so, they miss the opportunity to identify and address what is often a correctable underlying cause. If this is your first time on this channel, subscribe right now. Every week I bring you specific, clear information about what your body is communicating after 60. Let me start with the physiology of what normally happens to fluid in the body overnight, because this context makes the causes I am going to describe far more understandable. During the waking hours, the body produces urine at a relatively steady rate. The kidneys filter blood, manage electrolyte balance, and excrete waste products and excess fluid continuously. The amount of urine produced varies with fluid intake, physical activity, and the ambient temperature, but the process runs throughout the day in a fairly consistent background mode. At night, in a healthy body, this changes. The pituitary gland produces a hormone called antidiuretic hormone, also known as ADH or vasopressin. ADH signals the kidneys to reabsorb more water from the fluid being filtered, producing less urine and more concentrated urine overnight. The normal nocturnal pattern is for urine production to decrease by roughly 50% during sleep, allowing the bladder to fill slowly enough that a full night of sleep is possible without needing to empty it. In adults over 60, this system changes in several important ways. ADH production decreases with age. The kidneys become less responsive to ADH signaling. The result is that the overnight reduction in urine production is less pronounced. The bladder fills faster. And if the bladder itself has also reduced in functional capacity, as it often does with age, the threshold at which it signals the need to void is reached sooner. This is the baseline biology that makes nocturia more common after 60. It is real, it is documented, and it is not something you caused or could have prevented. But it explains 1 to 2 nocturnal voids in an otherwise healthy older adult. It does not explain 3, 4, or 5. And it certainly does not explain a pattern that has been worsening over the past year, or that is accompanied by other symptoms, or that appeared relatively suddenly after a period of having slept through the night. The causes I am going to describe are the ones that sit on top of this baseline biology and amplify it beyond the range of ordinary aging. The first cause is one that affects roughly half of all men over 60, and is one of the most common reasons for significant nocturia in older male adults: benign prostatic hyperplasia, or BPH, the non-cancerous enlargement of the prostate gland. The prostate surrounds the urethra, the tube through which urine exits the bladder. As the prostate enlarges with age, it compresses the urethra. The flow of urine is partially obstructed. The bladder has to work harder to empty completely. And crucially, because the bladder often does not fully empty against the resistance of the enlarged prostate, it fills again to the sensation threshold more quickly than it would if it had started empty. The result is a bladder that never quite resets. It holds less than it should. It reaches the urgency threshold faster. And overnight, when the reduced ADH production of aging is already allowing urine to accumulate faster than in younger years, the combination produces multiple wakings that are genuine, urgent, and not easily explained away by fluid timing. The key features that point toward BPH as a contributor are a urinary stream that is weaker than it once was, a sense of not fully emptying after urinating, the need to wait a moment before flow begins, and nighttime symptoms that are more prominent than daytime ones. Any of these features in a man over 60 with significant nocturia should prompt a direct conversation with a urologist. A simple prostate size assessment and a post-void residual measurement, checking how much urine remains in the bladder after urination, can confirm whether BPH is contributing and guide the appropriate management. BPH is treatable. Medications that relax the prostate or reduce its size have good evidence for reducing nocturia frequency. Minimally invasive procedures are available for cases where medication is insufficient. The key is having the conversation, which many men delay because they assume the symptom is expected at their age. The second cause affects both men and women, and it is the one that is most consistently missed because its origin has nothing to do with the bladder or the kidneys, and everything to do with where fluid is stored in the body during the day. Peripheral edema and nocturnal fluid redistribution. The fluid that accumulates in the legs and ankles during the day in adults with venous insufficiency, heart failure, or reduced lower limb circulation does not stay there when the person lies down. Here is the mechanism. Throughout the waking hours, gravity pulls fluid into the lowest part of the body. In an adult with any degree of venous insufficiency or cardiac preload issues, or simply the reduced circulatory efficiency that often accompanies aging, that fluid cannot fully return from the lower limbs to the central circulation while upright. It accumulates in the tissues of the lower legs and ankles. This is the swelling many adults dismiss as normal by the end of the day. When that person lies down at night and their legs are elevated to a horizontal position, the fluid that has been pooling in the lower extremities begins to return to the central circulation. The kidneys, now receiving a larger volume of blood than they did when the person was upright, respond by producing more urine. The extra fluid has to go somewhere, and it goes to the bladder. This redistribution process typically peaks in the first 2 to 4 hours after lying down, which is why adults with this pattern often have their most disruptive voids in the earlier part of the night. And the volume of urine produced in these early night voids is often larger than expected, reflecting the volume of fluid being cleared from the legs rather than simply the amount drunk before bed. The practical question this raises is straightforward. If your ankles or lower legs are noticeably more swollen at the end of the day than they are in the morning, and if your most disruptive nighttime urination occurs in the earlier hours of the night rather than in the pre-dawn window, fluid redistribution from lower limb edema is a likely contributor. This observation needs to be shared with your doctor because the edema itself may reflect something that warrants evaluation, including cardiac function, kidney function, and venous health. One simple intervention that often reduces the nocturnal fluid load significantly is wearing graduated compression stockings during the day, which prevent the lower limb accumulation from occurring in the first place. When less fluid pools in the legs through the day, less returns when you lie down, and the kidney load overnight is correspondingly reduced. In several clinical studies, daytime compression stocking use produced measurable reductions in nocturia frequency in adults with lower limb edema, sometimes reducing the number of nighttime voids by 1 or more. Type in the comments right now if you notice ankle or leg swelling by the end of the day and have never connected it to your nighttime urination. Because for many people watching this video, that connection is the piece of information that changes everything. The third cause is blood sugar, specifically elevated blood glucose from diabetes or from the pre-diabetic range that many adults in their 60s occupy without ever receiving a formal diagnosis. When blood glucose is elevated beyond the kidney's threshold for reabsorption, which is approximately 180 milligrams per deciliter in most adults, glucose begins to spill into the urine. Glucose in the urine is osmotically active, meaning it draws water with it as it is excreted. The result is a significantly higher volume of urine produced than would be expected from the fluid intake alone. The bladder fills faster. The overnight voids are more frequent and more voluminous. This is one of the classical presenting symptoms of undiagnosed type 2 diabetes. Along with excessive thirst and unexplained weight loss, polyuria, the production of abnormally large volumes of urine is one of the primary signals that blood sugar is out of range. Nocturia is often the feature that first brings people to clinical attention, because the nighttime disruption is more noticeable than the daytime urinary frequency that can be attributed to fluid intake. But it is not only frank diabetes that causes this. Adults in the pre-diabetic range, with fasting blood glucose between 100 and 125 milligrams per deciliter, can also experience glucose-driven changes in urine production, particularly overnight when glucose levels are less tightly regulated by normal behavioral cues. If you are experiencing significant nocturia and your blood glucose has not been checked recently, or if it has been checked but only a single fasting value was taken, rather than an HbA1c reflecting 3-month average glucose levels, ask your doctor specifically for an HbA1c. It is a standard component of a blood panel. It takes seconds to add, and it tells a far more complete story of glucose regulation than a single fasting reading. And if you are not yet subscribed to this channel, tap that subscribe button right now and ring the bell. Every week I come here with exactly this kind of information, because knowing which test to ask for is sometimes the most valuable thing you can take away from a video. I want to tell you about Margaret, 70 years old, retired school librarian from Austin, Texas. She had been waking 3 to 4 times every night to urinate for about 14 months. She had reduced her fluid intake after 6 in the evening to almost nothing. It had not made a meaningful difference, so she mentioned it at a routine appointment. Her doctor attributed it to age and bladder changes and recommended pelvic floor exercises. Margaret did the exercises diligently for 2 months, still 3 to 4 times a night. When she came to me, I noticed that her most recent HbA1c, taken 11 months prior, was 6.3%, pre-diabetic range, borderline, but her doctor had told her to watch her diet and had not followed up on it. I also noticed that her ankles were visibly swollen when she came in at 4 in the afternoon. She had been wearing loose shoes for a year because her regular ones felt tight by the end of the day. 2 separate contributors, neither of which had been connected to her nighttime urination. The blood sugar was driving osmotic fluid loss overnight. The ankle edema was redistributing into the renal circulation in the first hours of sleep. Together, they had been producing 3 to 4 nocturnal voids a night for over a year, while she did pelvic floor exercises that were addressing neither of them. We worked with her primary care physician to address both directly. Dietary changes to bring her glucose back below the pre-diabetic threshold, compression stockings during the day, and a small adjustment to the timing of one of her medications, which we will discuss when we come to the 4th cause. At 6 weeks, she was waking once, sometimes twice, a night. At 3 months, she told me she had had 4 consecutive nights of sleeping through entirely. She said, "I thought this was just my body now." I told her, "It was your body telling you something specific in the only language it had, and it had been telling you for 14 months. The 4th cause involves the medication cabinet that most adults over 60 have in their bathroom, and specifically the timing of certain medications that are driving fluid production at the wrong time of day. Diuretics, medications prescribed to reduce fluid retention, to manage blood pressure, or to support heart function. Furosemide, hydrochlorothiazide, chlorthalidone, spironolactone, and their equivalents. These medications work by promoting urinary excretion of sodium and water. They are effective, widely prescribed, and an appropriate treatment for the conditions they manage. But their timing has a direct and often unrecognized effect on nocturia. When a diuretic is taken in the morning, its peak effect occurs in the late morning to early afternoon, when the person is awake, active, and can respond to the urge to urinate without disrupting sleep. By the evening and overnight, the diuretic effect has largely subsided, and the overnight urine production is determined primarily by normal physiology. When a diuretic is taken in the evening, or even in the afternoon in an older adult whose kidney clearance of the drug is slower than it was at 40, the peak diuretic effect overlaps with the overnight window. The drug is driving fluid excretion at exactly the time when the person is trying to maintain sleep. The nocturnal void frequency increases dramatically, not because of the underlying fluid condition, but because the medication is doing its intended job at the wrong time. This is not a change to make without medical guidance, particularly if the diuretic is part of a cardiac management regimen, where timing has been chosen for specific reasons. But it is a question worth asking, and in many cases the answer from a doctor who has considered it specifically is yes, morning dosing is appropriate, and the nocturia reduction that follows can be significant. Additional medications worth discussing with your doctor in the context of nocturia include certain calcium channel blockers used for blood pressure, which can cause peripheral edema as a side effect and thereby contribute to the nocturnal fluid redistribution we discussed earlier, and certain medications for overactive bladder that paradoxically reduce bladder capacity in some patients through their anticholinergic effects. Bring your complete medication list to your doctor, including over-the-counter products and supplements, and ask specifically whether the timing or combination of any of your medications could be contributing to your nighttime urination pattern. The fifth cause is one that most adults have heard discussed in the context of sleep, but fewer have had explained in terms of why it specifically increases nocturia frequency. Nocturia, sleep apnea. Obstructive sleep apnea, the condition in which the upper airway repeatedly collapses during sleep, producing repeated oxygen drops and microarousals through the night, is one of the more surprising and consistently overlooked causes of nocturia in adults over 60. The mechanism is specific. During apnea events, when breathing stops and the oxygen level in the blood drops, the right atrium of the heart stretches in response to the increased workload of pulling against a closed airway. This stretching of the right atrial wall triggers the release of a hormone called atrial natriuretic peptide, or ANP. ANP signals the kidneys to produce more urine and to excrete more sodium. The body interprets the right atrial stretch as a sign of fluid overload and responds by trying to reduce blood volume through increased urinary output. A study published in the journal Sleep Medicine found that effective treatment of obstructive sleep apnea with CPAP therapy produced a significant reduction in nocturia frequency in adults who had both conditions, in many cases reducing the number of nighttime voids by 1 or more per night, without any change to fluid intake, bladder therapy, or medications. The reduction in apnea events removed the ANP signal that had been driving the excess urine production. The features that suggest sleep apnea as a contributor to nocturia are the same as those that suggest sleep apnea in any context: loud snoring, witnessed breathing pauses, morning headaches, dry mouth on waking, and daytime fatigue that does not improve with more sleep. If you have any of these features alongside significant nocturia, raising the question of sleep apnea evaluation with your doctor adds a dimension to the nocturia workup that is frequently missed. Type yes in the comments right now if you snore significantly and also wake multiple times a night to urinate and have never had a sleep study done, because the answer to your nocturia may be in your airway, not your bladder. Share this video with one person in your life over 60 who is up multiple times a night and writing it off as aging. You might be giving them the reason to finally ask the question that gets them an answer. The sixth cause is hormonal, and it specifically affects women in the years following menopause, though its effects on bladder function are rarely discussed as directly as its other consequences. The decline in estrogen following menopause produces changes in the tissues of the lower urinary tract that directly affect bladder function and nocturia frequency. The bladder wall, the urethra, and the pelvic floor tissues all contain estrogen receptors and depend on adequate estrogen for their structural integrity and functional tone. When estrogen levels fall, these tissues undergo a process sometimes called genitourinary syndrome of menopause, characterized by thinning, drying, and loss of elasticity in the urethral and bladder tissues. The functional consequences include reduced bladder capacity, meaning the bladder sends urgency signals at lower volumes of urine than it did before. Reduced urethral resistance, making it harder to delay voiding once urgency is felt. And increased bladder irritability, a lower threshold for the involuntary contractions that produce urgency and can drive frequency. In practical terms, this means that a woman who slept through the night at 52 may be waking twice or more a night at 67, not because her fluid intake changed, not because of any other medical condition, but because the tissues that once comfortably held urine through the night are now thinner, less elastic, and more easily irritated. This is an under-recognized contributor to nocturia in older women, and one that responds specifically to treatment, including topical vaginal estrogen, which has excellent safety data in older women when applied locally, and which restores tissue integrity in the lower urinary tract in ways that significantly improve both urgency and nighttime frequency. If you are a woman over 60 with significant nocturia, and this cause has never been specifically discussed with your gynecologist or primary care physician, it is a conversation worth initiating. Here is the practical framework I want you to take into your next appointment. Describe your nocturia specifically, not just that you wake up at night. How many times per night on average? What the volume of each void feels like, whether it is large and clearly a full bladder or small and urgent despite a limited volume. Whether the pattern is worse in the first half of the night or the second. Whether your legs or ankles are swollen during the day. Whether you snore or have been told you stop breathing during sleep. Whether you have noticed increased thirst or any change in your daytime urinary frequency, alongside the nighttime pattern. This level of specificity transforms what your doctor can do with the information. A general complaint of waking at night leads to a general response. A specific pattern description leads to a targeted diagnostic pathway. Ask about the following specifically, based on which causes I have described seem most relevant to your pattern. For men over 60, prostate size and function, including a post-void residual measurement. For everyone, HbA1c and fasting glucose if not recently checked. An assessment of lower limb edema and whether its cause has been evaluated. A review of your medication list with specific attention to diuretic timing, and any medication with bladder or fluid effects. A sleep assessment, including whether a home sleep study for sleep apnea is warranted. For women, a discussion of genitourinary changes related to estrogen decline and whether local estrogen therapy might be appropriate. None of these tests is invasive or expensive. All of them are within the scope of a thorough primary care evaluation. What they require is that you ask for them by name, rather than waiting for them to be offered unprompted. And the evening habits that reduce nocturia most consistently across causes are the following. Stop drinking fluids 2 to 3 hours before sleep, but ensure that you have consumed adequate fluids, at least 6 to 8 cups of water, through the morning and afternoon, so that you arrive at this fluid restriction already well hydrated rather than trying to compensate for a dry day in the evening. Avoid caffeine afternoon. Caffeine is a mild diuretic and a bladder irritant, and its effects persist in the system for 6 to 8 hours. Avoid alcohol in the evening, which similarly increases urine production and disrupts the sleep architecture that would otherwise allow the bladder to fill without waking you. Keep the bedroom cool, as a warm sleeping environment increases fluid losses through perspiration, which can paradoxically increase the drive to produce urine as the body tries to maintain its fluid balance. And if lower limb edema is a contributor, elevate your legs for 30 to 60 minutes before bed. This gives the pooled lower limb fluid a chance to return to the circulation while you are still awake, reducing the volume that redistributes in the first hours of sleep. 4 things I want you to carry away from this. First, waking once per night to urinate can be within the normal range for an adult over 60. Waking 2 or more times is not simply a feature of aging that requires no investigation. At that frequency, the sleep disruption has real health consequences, and the cause is almost always identifiable if the right questions are asked. Second, the most common causes of significant nocturia in adults over 60 are not all bladder problems. Fluid redistribution from lower limb edema, elevated blood glucose, medication timing, sleep apnea, and hormonal changes in women are all causes that require different conversations and different evaluations from a standard bladder assessment. The cause determines the solution. Managing the symptom without finding the cause is why so many people live with this for years, without improvement. Third, the specific pattern of your nocturia is diagnostically useful. When in the night it occurs. How much is produced? Whether it is accompanied by urgency or simply a feeling of fullness. Whether daytime swelling is present. These details are clinical evidence. Write them down before your appointment and bring them with you. Fourth, most causes of nocturia in adults over 60 are treatable, not manageable with behavioral adjustments alone. Treatable. VPH responds to medication and procedures. Edema-driven nocturia responds to compression and the management of the underlying circulatory cause. Glucose-driven nocturia responds to blood sugar management. Medication-driven nocturia responds to timing changes. Apnea-driven nocturia responds to CPAP. Estrogen deficiency-driven nocturia responds to local estrogen therapy. The path to a full night of sleep for most people is not accepting the symptom. It is finding the cause. You are not broken. Your bladder is not simply failing with age. Your body is communicating, in the specific language of nighttime disruption, that something is happening that is worth understanding. And now you have the understanding to do something about it. Share this video with someone who is getting up 2 or 3 times a night and has been told it is just getting older. And subscribe to this channel, because every week I come here with one purpose: to give you the specific information that helps you understand what your body is actually saying, and to take that understanding somewhere it can be used. Aging does not take away your body's ability to recover. It simply reminds you to care for it the right way. Take care of yourself.